Perfect. And can everybody see the actual slideshow, not my notes page? Cool. Perfect. So yeah,
No, I lied. We can see your notes page, just like if we
oh, you
can see your
can?
full slide and then the next slide notes section. There you go. That's good.
Is that better? Cool.
Yep.
All right. So yeah, so I'm James Mahoney, clinical neuropsychologist by training, for those that don't know me. I also lead some of the neuromodulation efforts over here at the RNI. So that's what I wanted to talk about today, specifically involving focused ultrasound neuromodulation. We've had some really nice preliminary results that I'll talk to you about today. Um, so some of the results that I'll be discussing are funded by the National Institute of Drug Abuse under the HEAL Award. And yeah, so just to start, so transcranial magnetic stimulation was one of the initial forms of neuromodulation that was looked at. We have some studies going on here at the RNI. It's also being used clinically for depression. Um, the TMS, it's really focuses on those more cortical areas of the brain, so the dorsolateral prefrontal cortex, obviously highly implicated in addiction and substance use disorder. Um, there's also other forms of neuromodulation, such as deep brain stimulation or DBS and focused ultrasound. We've recently had some studies with deep brain stimulation as well. One of the obvious drawbacks with DBS is that it involves an invasive surgery. The electrodes are implanted deep in the brain. So you have all the complications that go along with that. But it's able to get at those areas with like really great specificity that TMS can't. Um, Focused ultrasound seems to really address both of the limitations that I talked about with the other forms and doesn't really have as many negative limitations to go along with it. So you're able to non-invasively focus in on those subcortical deep regions of the brain. So that's what I'm going to talk about today. Um, when we look at the reward circuitry that's associated with addiction, there's a ton of different areas. It's obviously very complex. There's not just one specific area. We look at the center being the nucleus accumbens. We look at that as being the center of the reward circuitry, but there's several surrounding areas. Also, of course, the dorsolateral prefrontal cortex involved with decision making and planning, those types of things, which are often impaired with substance use. All of these are implicated in the addiction cycle. The dysfunction of at the nucleus accumbens level, the dysfunction is really what's thought to keep the persistent drug-seeking behavior, the craving, those types of things that are then going to influence an individual's ability to stay abstinent and to stay engaged in treatment. So the hope is that if we're able to regulate these specific regions of the brain, individuals will have more success at staying engaged in treatment. They'll have their cravings reduced. They'll have their anxiety and depression levels reduced so that they can have more successful outcomes. And if at any point, please just jump in. I know I talk fast and I know that I don't slow down, but please just, try to throw something at the screen and maybe I'll see it and let me know. So a little background on focused ultrasound. Focused ultrasound's been around for a really, really long time. There's two primary different forms, well, three really. The first one's high intensity. High intensity is used where the ultrasound waves are used to ablate or create a lesion. So the temperature is high enough where you're able to destroy that area of the brain. So this is for like tremor and Parkinson's disease. If you have a specific area of the brain that's contributing to that tremor, once you ablate it, and you can see this, in the videos, and you can see it almost real time, but you ablate that area of the brain, then the tremor just stops. So that's high intensity. There's low intensity, which is used with microbubbles for blood-brain barrier opening. So that's a different form. It's not causing an ablation, but basically it's causing these microbubbles to vacillate enough and basically just reverberate, which opens up the blood-brain barrier temporarily so that you can have targeted drug delivery. And of the most importance is the blood-brain barrier then closes. Um, so it's able to facilitate targeted drug delivery. And then the third form is for neuromodulation, which I'll talk about today, which we're doing here as well. We've completed, I think, 34 patients with substance use disorder, another 4 patients with binge eating disorder now. So we have some nice preliminary results for those populations. So I'll talk a little bit about that today. Here's the description of all the different types of devices. There's, focused ultrasound can be administered several different ways. And this is just to kind of show you there's these single transducers, there's multiple transducers. The one that we use is this is this Insightec Exablate device. So this is MR guided. So the ultrasound is actually delivered while the individual is in the MRI machine. That way we're able to kind of look at the target the entire time that they're receiving the sonication. And this is the way that it's set up here. You can see the individual have a head frame on, and they have this helmet, which has all these thousands of transducers on it. And then you're able to, with the MRI, pinpoint, the targeted location, and then the energy gets delivered through those thousands of transducers and meet up at that central point. So you don't have too much area of the brain that you don't want to get targeted. Not too much is getting a lot of energy at one time because it's coming from all these different directions. So it's considered a non-surgical outpatient or minimally surgical. Now, as I said, they have to have a head frame, so they get pins. So that we basically put in nerve blocks here and put a head frame on. But we have the procedure down so that it's minimally painful at this point. They'll lay down on the MRI machine. They'll have that helmet on, and then the helmet also there's a bladder in there that fills with water for cooling. But it's a relatively quick procedure, usually lasts about an hour or so. You can also, instead of the head frame, you could do a frameless dental mold, which is basically just like a bite bar. So they don't have to have the head frame. We thought that that would be an easier option. We tried it with a few participants, but for 2 reasons, it didn't work very well. One reason being, it takes another sensory out for patients to be able to communicate with us, which created a lot more anxiety for them because they couldn't speak. And another thing too is that you have to have pretty good dentition for the dental mold to hold, and our population doesn't always have the ideal dentition for that. And then we're able to target the nucleus accumbens and the ventral internal capsule using tractography, using the different MRI software to make sure that we're hitting the location that we want to target. And as I said, it takes about an hour from start to finish. So we first started with this focused ultrasound for addiction back in 2021. It had never been looked at before, so we went to the FDA and they said, okay, you have to look at a really low, what we would have considered a non-therapeutic dose, just to make sure that it's safe and it's well tolerated, that this is going to be feasible. So we did that, and then the FDA said you can increase the dose, which we did, and had some nice findings, some nice preliminary findings. This is looking at we would target the left nucleus accumbens and then the right nucleus accumbens. So we showed that it was safe, tolerated well by the participants. Went back to the FDA and said, well, can we continue on with the study, move on to the next phase, looking at it bilaterally so that the sonication occurs and gets both sides, both hemispheres of the nucleus accumbens at one time with that higher dose. And they said, okay. So we ran an additional 16 participants through that protocol. And we put out a case report once we first started, and then we just recently, this has just came out a couple of weeks ago, a pilot study in 8 participants with primary opioid use disorder. So I'll present some of those findings today. So primary, obviously, have to continue looking at the safety and tolerability of this. And then secondary objectives, we wanted to look at substance craving since that was the main thing that we were trying to reduce, and then substance use and then functional connectivity. Eligibility criteria. So we recruited patients from the Center for Open Healing. So these are individuals that were, more severe in their addiction. Many of them had tried and attempted outpatient care but didn't have success. So we also found that it was a really good way for us to be able to monitor them both before the screening process is quite intensive and the aftercare after the procedure. It's always good to be able to monitor them at least in those first week afterwards. So we felt better about, performing the procedure and then having them back over at Center for Open Healing. So that's why we chose that recruitment site. And then eligibility, they also had to have primary opioid use disorder, except for those two that we tried for methamphetamine use and alcohol use without opioid use disorder. But everybody else had primary OUD, and they had to be compliant with their medications for OUD for at least a week prior to enrollment. A lot of people will be like, well, I thought that this was supposed to be like treating their opioid use disorder. Why would they have to be on medication? We never look at this as being something that's just going to flip the addiction switch and make it so that you don't need medication anymore, or for addiction, you don't need any sort of behavioral treatment for your addiction. We view this as just being another way to supplement for the standard of care. So we look at this just another treatment arm. We want patients and individuals seeking treatment to continue with those other treatment methods. This is really just to help those that have struggled even despite those other treatments so that they could have success with the standard of care. And then here is the study design. So screening and baseline. Here are those outcome assessments I mentioned. One of the primary ones, what we do is what we call, it's not just craving, but it's looking at cue-induced substance craving. So patients will come in, we'd have them look at different pictures of neutral cues, and then we give them pictures of addictive cues or cues associated with addiction, and they would rate it from 0 to 10 using one of these, using a cursor on the bar. And we would be able to personalize this to make it so that, if they used IV primarily, or if they use smoke primarily, or if they use meth with heroin, we were able to individualize the pictures and the cue sets to the individual to elicit as much of a craving response as we could. And we would do this before at baseline. And then during the procedure itself, we would measure their craving level again. And then they would be in the MRI, so they would have to look at the images in these using the goggles. But they would look at the images during the procedure, during the sham procedure, and then also during the active procedure when they're receiving the actual sonication. And then we would measure their craving levels again. But we would also do different types of mood testing and measure their cognition, various other variables as well. So here is I'll just jump right into the results. So for the 16 patients that received the bilateral, as I mentioned, 14 of them were primary opioid use disorder, and then there was one each meth use disorder and alcohol use disorder. For the 14 that were opioid use disorder, all of them were polysubstance users. So most typically methamphetamine, although many used cocaine as well. Benzos were popular. So there was nobody that was truly just solely an opioid user, which is one of the benefits of this type of treatment when you think about it. While buprenorphine is effective at controlling opioid cravings, it's not really doing anything for meth cravings or for, benzo cravings. By focusing and targeting the center of the nucleus accumbens, we're really able to address cravings for all substances and all really, addictive behaviors. We've seen some carryover of this into like gambling. And as I mentioned earlier, we've started it with binge eating, which can be, considered a similar kind of more impulsive type of disorder. So I'll skip through. So safety and tolerability, didn't see any unexpected AEs. Didn't see any of those structural brain changes. We also didn't see any changes in the naturally reinforcing or pleasurable behaviors. So a lot of when we started presenting this data, people would ask, well, what about other stuff? So sure, they're not craving substances anymore. They're not craving drugs anymore, but or what about food? What about, water? What about just like everyday life, naturally reinforcing behaviors? And we could say no, we knew qualitatively ad hoc that wasn't the case because when people would get done with the procedure, they'd immediately be like, I'm hungry because we had them NPO for a few hours before the procedure. So we knew that, but we started giving some of these, the Snaith-Hamilton pleasure scale and the neuro quality of life measures, really to confirm that there were no changes there, and there were not. They actually reported higher satisfaction with some things in life because they reported not having as much of the distraction caused by the substance use that was interfering with their enjoyment of those activities. So here's once again the cue-induced craving. So here's what the median opioid craving. Um, this is the baseline. So this is for the folks that were primary opioid use disorder. So on the vertical axis here, we have from 0 to 10, 10 being most craving ever. So you see baseline is about a 6.5 out of 10. They would get the FUS procedure done, and then day one, you can see it dropped to about less than 1, which was quite shocking. And then the fact that it stayed low, throughout the 90-day follow-up, equated to approximately 91% decrease in craving for various opioids. And then this is looking at all the other substances. You got stimulants here, and then benzos, cannabis, alcohol. Not necessarily other than nicotine, not necessarily as high as for opioids, but once we had the treatment, you see day one much less, and then throughout the 90-day follow-up. So we see those acute changes after a day, but they really do say sustained, for up to 3 months afterwards. We're doing longer term follow-up with these folks now, and they stay low. Sometimes cravings return. There might be a period where, 3 to 6 months following the treatment might be may warrant for like a second focused ultrasound treatment, like a follow-up, more of a maintenance session. But we're still kind of looking into really what the best time is there to have that done. Emotional symptoms, they didn't come in with very high depression. Anxiety was a little bit higher. You can see after 24 hours after the procedure, get some reductions in anxiety and depression, which then stay lower throughout the 3 months post-treatment. And then substance use, of course, we can change craving all day, but if it's not going to affect their actual use, then maybe we're not looking at the right thing. So here is the urine toxicology results across the follow-up visit. So day 1, day 7, day 30, day 60, day 90. So you see that there were individuals that did return, that did have a relapse. Now all of the folks enrolled here, were for, months, years, several times a week, if not daily, users of various substances. So the fact that there were some sporadic uses is not completely, doesn't make it a failure, I should say. A lot of folks will be like, well, but did it really work if they did? Well, yeah, because a lot of these were just isolated relapses, and once the relapse occurred, the individual would contact the peer recovery coach, they contact one of the team, and get back and re-engage in treatment almost immediately. Whereas in the past, the trajectory would usually be to continue using, and then overdose, and then or end up in the ED, trying to get back into detox. So they would reach out and seek help sooner. So I think we learned a lot from the folks that did relapse, that did have a drug use recurrence, in terms of kind of what does it mean afterwards? Do they take the kind of the same route that they had in the past, or are they able to reinitiate treatment quicker? And here's a self-reported days of use. A lot of folks would be completely abstinent, but you could see there the ones that had some isolated uses, it was much less than their baseline amounts. And then some MRI findings. So they did MRIs. Safety MRIs were done regularly, before the procedure, and then during, and then day one, day seven, throughout. We also looked at it for connectivity. What we saw here was that there was reduced positive connectivity following the focus ultrasound in the dorsolateral prefrontal cortex, and then also in the posterior cingulate cortex here. So these are areas that are involved with, for example, executive functions, thinking, concentration, those types of things. So the fact that we're able to reduce the positive connectivity, we look at it as being like hyperactive. So a reduction of that is actually it's actually a positive thing, because it shows that there's more regulation that's going on. And then here's just some, more behavioral and functional changes. One of the things that patients consistently said was that they had difficulty connecting to the cues. So they would look at the cues, and they would be they would get done with the procedure, and they wouldn't really know how to respond. We'd get them out of the scanner, and they'd be like, "This is really weird. I can't explain it. I was looking at the pictures just now, and it was like they were neutral pictures. Like I didn't make me want to use, didn't make me feel like using. I had a hard time, thinking about what I was using in the past." And then they would be like, "That is so different than the first time I did it, or earlier on when it was the sham procedure." They're like, "Yeah, I was feeling it. I wanted to use." So there's this disconnect that happens during the procedure itself, and it carries over into, the night of. We didn't even think to ask questions about this at first, but talking about dreams and thoughts throughout the day. But a lot of folks would say, like, "Yeah, now that I think about it, I haven't had a dream about drugs since the procedure." And they were like, "I used to dream about it all the time. I used to dream about going to get drugs. I used to dream about using them. And then I would wake up and I would feel distressed and I'd want to use real bad." So those are the kind of anecdotal things that came up after the fact, where, we didn't expect that would happen, but we started hearing it more and more. So now we're doing more of a thorough investigation, more strategic, and kind of how we're getting that information during our current trial. Um, and then, improve mood, better focus, life engagement, um, and just really better engagement overall, but especially with treatment too, because staying, in their treatment programs, attending all their appointments, making it a priority. So here's just a summary of everything I just said. Um, yeah, so we saw that reduction in, well, first off, it was safe. Saw that reduction of cravings, acutely and sustained throughout all follow-ups. Urine toxicology was consistent with that reduction in use. Saw those behavioral improvements. Um, saw those changes in MRI. And here's where we are now, long-term follow-up assessment. Want to spend more time optimizing the target location. This is definitely relatively novel, so we still have a lot to learn in terms of the mechanism. We're not entirely sure how the mechanism of action works for neuromodulation, so we need to continue doing preclinical studies, which we've recently initiated. Look at clinical trials for non-opioid substances, methamphetamine, especially with there being no medication available currently, and the fact that there's so much of it around. Um, and then also looking at high-risk populations as well. And then doing multi-site collaborations to replicate the findings with others. And then we also recently, or not so recently now, but about 6 months ago, started a randomized sham control trial here. We just enrolled our 12th participant, which is basically this is what it looks like. They'll screen just like they did with the open label. Once they're eligible, then we'll randomize them to either add the active focus ultrasound arm or the sham or placebo arm. Uh, we'll follow them for 12 weeks throughout the primary endpoint, do all the assessments, and then that's when we'll break the blind. For those folks that receive sham, they'll cross over to receive active focus ultrasound, and then we'll follow them. And then everybody gets followed throughout a year post. And then, as mentioned, binge eating disorder, currently enrolling. We just finished up our fourth participant, and things are going really well there. Finding also significantly reducing food noise and binge eating episodes. Planning on starting a PTSD study in the middle of 2025. And then, as I mentioned, like behavioral addictions, we've seen, retrospectively, we've seen people say like, "Oh, I just noticed I haven't been gambling as much, so we need to come up with some more well-designed trials for that." And then, yeah, treatment parameter optimization, co-occurring disorders like depression and anxiety, and then also the different devices as well. The device we have now works, and it's not the most scalable. My idea would be once we're able to really show the focused ultrasound has the strong effects and can reduce craving and reduce use. We want to make this as scalable as possible and get it out to clinics all across the country. There's only us and one other site that can use the Insight Tech device right now. There's going to be more over time, but if you need an MRI and need the really expensive hardware, it's not as practical. It's not as scalable. So the hope is that we're able to continue developing these other devices that are going to make it much more accessible so that we can really get it out there to all the people because a lot of people need it, obviously. And here's the team. Obviously takes a lot of us, a lot of different departments, a lot of different faculty, staff, just a lot of team members, all doing their respective parts to make the machine work. And that is where I'll end it and open it up for questions.
Dr. Mahoney is David Baltiera, family medicine. So I'm assuming you probably had scores for differences in the craving on the sham procedure, and how was that? And then, if these people came out of Center for Hope and Healing, do you have kind of a match control on how people did with, the residential treatment as that? And it looks like you're obviously doing a, kind of randomized in the future, but on that would provide some more robust data.
Yeah, absolutely. Let me see if I have any of that here. So I could tell you, I don't have any of the data in this presentation,
Just
but
generally, yeah.
yeah, for the sham, for the group, there's two different types of shams that we do. So for the data that I just presented, they would all get a sham sonication first. So they would just get a 0 watt where we would do baseline testing, and they wouldn't know that it's not going on. Everything else was set up the same way as an active one was. And there was no change in craving. So we got the straight line that we wanted. I could say now with the randomized control trial that we have where half the group is getting sham for the 12 weeks and we're following them for the full 12 weeks, there will be placebo effects. And we've seen that where people, report that their craving drops during the procedure. And then we find out 12 weeks later, well, there was no procedure because you got 0 watts. And that's a real thing. Placebo effect is a real effect. But for those folks, we would notice that after the first few weeks, their craving levels will go up. They would, also return to use. It's still very early on. We've only unblinded a total of 8 of them. Only 8 of them have reached the 12-week mark. But it goes to show that the sham does, it shows what it needs to show. It shows that there is a
Right.
sham effect additionally, and then people return. And then your second question is a great one. And that's one thing that we realized early on. And that's what we're doing as part of the randomized control trial. We have that kind of treatment as usual arm where we're doing all the same assessments, all the MRIs, all the follow-up assessments at the same time points. But as individuals that weren't, they were excluded and not able to participate in the ultrasound study for some other reason, whether or not it was a medical reason or they didn't want to, or, something like that. So we're basically following them the same way as if they got the procedure but didn't.
Okay, great.
Yep.
Yes, if nobody else, another quick, just a comment.
Yeah.
Your level of anxiety and depression seemed incredibly low for the patients that I take care of, at least.
Yeah.
So I don't know, it just that's and that is part of it is huge. And again, just a comment, it just seems much lower. I would put our rates at 40 to 80% of that.
Yeah.
So
No, you're right. And that's one of the things too. So with the inclusion exclusion criteria, it's very difficult, to really screen these folks because they could have depression, they could have anxiety. They couldn't have a primary MDD that was like
okay,
over,
got it.
yeah, which isn't necessarily reflective of the true population, but a lot of times they'll be able to get their depression better managed with because they're coming out of CHH. So they've been there for a couple of weeks. They've started getting the behavioral treatment. So it's probably not as high as it would be as they for when they first got in. So it's somewhat regulated, but it is low. It is lower than you would expect.
I have a question for you.
Yep.
In that study, it showed one person with methamphetamine only use and then alcohol use, one for each. How did they get in this study? And does the current study recruit people like that who just have single uses without opioid use disorder?
Yeah, so for the open label study, it was the way that we set it up initially was for just opioid use disorder, and then we eventually opened it to we wanted to just get some pilot data to see if it worked for other substances, which we anticipated it would, but it was really just to get pilot data for like alcohol specific, so that we could start looking at that population that had an alcohol use disorder without any other comorbid SUDs, and the same with methamphetamine. So, basically our protocol and the investigational device application with the FDA allows us to look at other substances. We just wanted to make it as many of them as opioid use disorder as possible. Yeah, because that was really the nature of it initially, and that's how we were planning on it to be all just opioid use disorder. But when we started seeing the results, we wanted to see how it would translate into other SUDs too, and we didn't expect that it had to be OUD plus, that it could be just methamphetamine use or just alcohol use disorder alone. But we wanted to show it a little bit, so that's why we just ran a couple cases.
But like the current study, the randomized study that's going on now, can someone have just simply, not simply, it's not simply, but like methamphetamine? Because we see that a lot.
Yeah, so that we cannot. So for the randomized control trial, it all has to be primary opioid use disorder. So they have to have that. They can have co-occurring methamphetamine use disorder, but they have to have a primary OUD. We do have other studies coming online, though. We have a pilot trial that I anticipate will start probably in about 2 to 3 months. So it'll be open label, but it'll be specifically for methamphetamine use disorder.
Good, thank you.
Yep.
So is
Curious
the
what,
ult oh sorry, go ahead.
I'm just curious what you're seeing with nicotine use disorder, because it looked like from one of your slides that maybe you had less of a response with nicotine than other substances, or maybe I'm not interpreting that
No,
correctly. So
no.
just curious what you're seeing.
No, that is, you're right. It seemed like when it comes to craving, um, and really ad hoc, participants would say that they were smoking less, maybe, but definitely not as responsive as it was for like for meth or any of the illegal substances. A lot of that may also be because no one said that they wanted to stop smoking, so they weren't actively trying to stop either. But I brought that up and I said that, that's something we need to look into very soon, is for individuals that have failed, the traditional smoking cessation trials of medication treatment and other behavioral treatments, you know, try this out for them specifically, and see if we could really have an effect there as well. So yeah, I think because a lot of it, we do know that motivation's a huge part. And the people that we enroll were definitely motivated, to stop, using whatever illicit substances they were using. And when we think that the whole buy-in and the whole commitment is still very much necessary. So I think if we were to try a study for nicotine for people that really did where they were committed to stopping but just weren't able to with the standard of care out there, I think that we would really have success there too.
So, so is the ultrasound kind of turning off the nucleus accumbens, upregulating? I mean, just in a simple way, just
Yeah.
trying to keep it in my brain, kind of, are we upregulating, downregulating? I mean, obviously we're
Yeah.
not frying it.
Yeah. So we're definitely there. So no lesioning, none of that.
Right.
I think what do you say, up regulation, down regulation? My answer is yes.
Okay.
It's honestly probably both. And I think that there could be an argument made for either one or both. And that's part of the work mechanistically. What we need to figure out still is how exactly it's working, because a lot of it too is going to come down to, like for example, with TMS, if you use a certain frequency, it's inhibitory versus excitatory. We still need to figure all of that out for ultrasound, and it's much more earlier on, unfortunately, or fortunately. It just means that there's a lot to learn, and we are working backwards here because, we saw this profound clinical effect, and now we're trying to figure out why exactly we saw that clinical effect. But, we'll continue doing that in parallel.
Okay. So it could be overstimulating it, turning it down, right? Any of that's possible, right?
Yeah,
Okay.
absolutely. Yeah, absolutely.
Methodologically, how long do you think you need to follow people up before you can say this is really ready for to be rolled out more broadly?
Yeah, it's a good question. And we've had some talks. It's more about like what's it going to take for it to be FDA approved? How long would it have to show that how long of an effect? I mean, I would say that if we're able to show after 90 days, if we're able to show a reduction in, X% of people that is able to kind of show that there's not reduces the susceptibility for a relapse in 90 days, that should be sufficient enough, because if you can then retreat that person, and then, nobody would really necessarily want to get retreated every 3 months. But like if you were to do that, it shows that you could have a long-standing benefit from each one of these sessions. So, you know, uh, when we first started this study, I'll tell you right now, like where we are now versus when we first started. When we first started, if I saw a reduction on the table during the procedure itself, like by like 10%, that would have been a win for me, because, we hadn't been able to see that with even with medications. We saw some indication, but like if we were able to see a reduction of when they got the sonication, I did not expect there to be a reduction in craving a day later, a week later, certainly not so a week longer. Like I did not expect that at all. Um, so I think the fact that we were able to see it so quickly, it's going to give us more opportunity to optimize it so that we're able to really make it so that you can hopefully, with a single treatment, have lasting treatments. I mean, lasting effects up to 6 months, and then people can get maintenance, come in and get maintenance treatments to kind of carry them over, and then hopefully reduces more and more. So I know that didn't answer your question, because a lot of it's going to be in the control of the FDA and kind of what they think, and we're going to probably move towards pivotal trials, probably in the mid part of the year. We have this RCT right now, so we'll see what the results say. But we'll probably, and the outcomes are generally 12 weeks. So if we're able to continue to show that there's going to still be that reduction in craving or use after 12 weeks, I think it could definitely get on market.
Comparing
Couldn't
this
you,
with TMS at all? I know it's real early and all that, but I mean, early data, was it similar, different, ballpark?
Um, so the TMS for like the SUD, like
Yeah. Hmm.
so yeah, so I mean, I would say that the effects, so there's two main differences here. The fact that it's a single treatment with the focused ultrasound versus the daily sessions for weeks. And the fact that the results have been for the single treatment of focused ultrasound seem to last longer. The craving reduction seem to last longer. I would say that it's probably superior, but I mean, I love TMS too, so I'm not going to say that TMS doesn't work. But I think it just shows that there's different. I look at it more as like kind of like the continuum, T and I'm also all about like considering alternating TMS and ultrasound as well.
Right.
Once we get there, where you can hit the more kind of diversely kind of hitting the cortical areas of the brain, and also focusing in on very specific subcortical areas, and get like the planning and the organization and the executive networks up here, and then get the craving at the same time, or alternating. So I think focused ultrasound may be a quicker way to kind of get the treatment done. Um, But I mean, but TMS works too. So
Right.
yeah,
But fairly dramatic and also is a, like you said, all the therapies. It's not one either
not
or,
right.
even medication and all that. So that's
Absolutely.
helpful. Yeah.
Absolutely.
All right. Thank you so much, Dr. Mahoney. I'm going to go ahead and stop the recording.